Good afternoon and welcome to the BASHH Symposium. I'm Kath Mercer and I'm joined today by Nigel Field and Kirsty Mitchell from the Natsal team and Claire Dewsnap and John McSorley from BASHH, who have kindly invited us to speak on understanding sex and sexual health in the COVID-19 pandemic. And so without further ado, I'll share my screen and we can get started.
We can see that, Kath. Thank you.
Great, thank you. So this is a symposium of two halves. Shortly, I'll hand over to Kirsty and Nigel to present findings from Natsal-COVID. And then in the second half, I'll reflect on some of the methodological challenges and opportunities for Natsal to come out of the pandemic. And just to add that there will be time for questions following each of the presentations, which you can submit at any time via the chat. Firstly, I want to begin by acknowledging that Natsal is very much a team effort, led by myself and Pam Sonnenberg, who unfortunately is unwell with COVID, and so can't be with us today. And so on behalf of myself and Pam, I'd like to say a big thank you to our colleagues and friends at UCL, the University of Glasgow, the London School of Hygiene and Tropical Medicine, and NatSen Social Research, but also to many of you who are collaborating with us on Natsal. So as a very brief reminder, Natsal is Britain's national probability sample surveys of sexual health, which have taken place more or less every 10 years since 1990, and to date has interviewed over 45,000 men and women living in Britain born throughout much of the 20th century. Natsal was initiated in the mid-80s in response to the emergence of HIV and the realization of a need for robust epidemiological data on HIV risk behavior, but has evolved to become, with each round to take a broader perspective on sexual health. In Natsal 2, considering STIs more broadly than just HIV, before considering sexual health in its broadest sense in Natsal 3. Natsal 4, which we'll be fielding next year, will continue to adopt this broad perspective, whilst also considering the context of sex and sexual health in Britain in 2022, reflecting the major societal shifts that we've seen over the past decade, including greater recognition of gender fluidity and diversity. So although Natsal's remit has broadened, and as you can see from this figure, some methodological elements have changed over time, such as the size of the survey, the eligible age range, and the STIs that we test for, and that as part of Natsal 4, shown at the bottom here, we're looking to enhance the survey and biological data we collect by linking to routine data sets and health records. But crucially, at the heart of Natsal is its unique ability to provide the population perspective in the jigsaw of evidence needed to design and evaluate sexual health services and interventions. Yet, as we all know, this critical area of our lives is highly stigmatized and highly sensitive. For these reasons, sexual behavior, its drivers and consequences are difficult to research. For example, it's difficult to address them well with just a few questions tagged to the end of a general health survey or in a survey just to people attending services. Methods are needed that maximize response and minimize bias. We can't ask questions that are subjective or vague, like, have you cheated? It's for this reason that following the difficult decision last year to pause preparations for the next decennial Natsal 4, we decided to use our experience from undertaking almost four rounds of Natsal to investigate the impact of COVID-19 on sexual behaviour and sexual and reproductive health in Britain. As despite being fundamental areas of our lives, these these topics were largely overlooked by other studies examining COVID's impacts on health and well-being. And so Natsal-COVID was born, which Nigel Field and Kirsty Mitchell have been doing an absolutely stellar job leading over the past somewhat turbulent year. And so I'm really thrilled that we're able to share results from Natsal-COVID here at this ISSTDR. I'll stop sharing now and hand over to Kirsty to speak on Natsal-COVID.
Does that look okay?
Fantastic.
Great, thank you. So thank you very much, Kath, for the introduction. On behalf of the Natsal-COVID team, I'm pleased to present our headline findings. I'm going to introduce the methods first and present some data on sexual behaviour, and then I'll hand over to Nigel to tell you about the health service use, including the uptake of testing and screening. I'd like to acknowledge this as a huge team effort and highlight the brilliant work of our analysts, Emily and Malachi, our core team of Julie, Raquel and Anne, and our Natsal PIs, Pam and Kath. So no conflicts of interest to declare. Well, this slide pretty much sums up life for everyone right now. And there's some irony in showing it to you as I present in a conference symposium, apparently, but on my own, in front of my computer, unable to really even see or know who's listening. And the suggestion here is that sex, like everything else, has gone online. But did it really? And it was the questions like these that motivated us to do the Natsal-COVID study. I've shown this slide several times. It comes from the Information is Beautiful website. It looks great, but it also highlights how sexual intimacy has been overlooked as a risk of COVID transmission. Despite being far more common than activities such as bowling and involving the closest contact, it's missing from this slide of riskiest activities. And also restrictions on household mixing have glossed over the fact that from the perspective of sexual intimacy needs, the ask has been much greater for some than others, and I'll return to this point later. So to the objectives of the Natsal-COVID study. The idea was to rapidly understand how sexual and reproductive health in Britain has been affected by the COVID pandemic, focusing on sexual activities and behaviours, relationship and sexual difficulties, including violence, and service use and uptake of interventions. Apart from the self-evident scientific interest, our purpose was to provide data for policymakers tasked with designing and providing services during and after the COVID pandemic. We worked with Ipsos Mori to undertake an online panel in 2 waves, 4 months from the first UK lockdown and then 1 year into the pandemic. In both surveys, we had a core eligible sample of 6,000 people aged 18 to 59, with a boost of 500 of young people 18 to 29. We used sample quotas based on age, gender, region, and social grade to approximate the general population. Knowing that attention spans for online services are short, we kept the questionnaires brief, and it took around 10 minutes to complete each survey. Ipsos Mori used quality controls to assess errors and remove participants with suspicious completion behaviours. And then prior to the analysis, we weighted the data on age, gender, region, social grade, and also ethnicity and sexual identity with the aim of achieving a quasi-representative sample. This slide sets out our fieldwork periods alongside key dates in the UK pandemic. We conducted our first survey in late July-August 2020, 4 months from the start of the first lockdown. In October-November, we conducted 45 qualitative interviews just before the start of a second full lockdown in England. Then the second survey took place between March and late April 2021, 1 year after the start of the very first lockdown in UK. And then between these periods of full national lockdowns, there were local lockdowns and periods of tightening and loosening restrictions. Here we just see the same time frame and the periods of reporting for each of the 3 data collection points. So there were 4 months of period reporting for the first survey, 7 months for the qualitative interviews, and 1 year for the second survey. It was not by our design, but as it turned out, both surveys were conducted at the end of 2 full lockdown periods lasting 2 to 3 months. Now, we've only received the clean data for the second survey a few weeks ago, and our team have done an amazing job to pull this together, but please do accept these data as highly preliminary and a first peek. Here, very briefly, is the questionnaire content. It covered demographics and attitudes to the pandemic, health, sexual history and partners, sexual and romantic lives during the pandemic, digital and online activities, including porn, sexual function, pregnancy, including unplanned pregnancy, service use and access to services, chlamydia and HIV testing, contraception, intimate relationships, and intimate partner violence. So to the results. So I'm just going to focus on sexual behaviours and mostly among ever sexually experienced participants. So let's begin with data from the first survey 4 months into the pandemic. We found that 63% reported ever having sex with someone since lockdown, 3/4 of whom were in cohabiting relationships. Most of this period was in a full lockdown in which sex across households was prohibited, and so cohabitation was a key factor in behaviour. We found that compared to those in cohabiting relationships, participants in casual or non-cohabiting relationships reported less frequent sex and more frequent masturbation, sex toy use, and virtual activities. And if you're interested, you can hear more about this presentation in presentation 5.5 in the conference by Mercer. Moving to the second survey, we asked participants how many new partners they'd had in the past year of the pandemic. And this slide shows men in green, women in orange. Around 1/3 of the participants in the youngest age group reported a new partner. And we can see a decline in reporting new partners by age. We also see that men reported more new partners than women. But is this more or less than we'd expect? To get some sense of this, we looked back at data from the Natsal-COVID survey and data collected between 2010 and 2012. And we present this for context and do so with caution. 10 years have passed since these data were collected, and that's a long time when it comes to trends in some aspects of sexual behaviour. And there are also key methodological differences, including that Natsal-3 is a probability sample, whereas Natsal-COVID is a quota sample. But with these caveats, the data shows that from Natsal-3, the data shows that Natsal-3 in hatching and the data in from Natsal-COVID in bold. And with these caveats, we see that the data suggest a drop in the proportion of people reporting a new partner, particularly among young people. And these drops can be seen for men as well as women. We can also break this comparison down by the number of new partners. And this slide shows Natsal-3 data on the left and Natsal-COVID on the right. And we can see evidence of far fewer new partners at a population level, with more people reporting no new partners in the past year than in 2010, and fewer people reporting 1 new partner, as well as fewer reporting higher numbers of partners. And although to some extent this suggests a reduction in a key driver of STI transmission, it's worth noting that 2/3 of those reporting a new partner also reported not using a condom the first time they had sex with that partner. Looking specifically at men who have sex with men, we also find a reduction in proportions reporting 2 or more partners, and an increase in the proportion reporting no new partners. An increase of about 10% of the population reporting no new partners. But again, please bear in mind our caveats around comparison with the Natsal-3 data. So pausing for a moment in our story about the impact of COVID on sex, let's look at the impact of sex on COVID. One of the many hard things that people were asked to do during lockdown was avoid contact with people from other households. And this was particularly difficult because it was a much bigger ask for those who were single or living apart from their partner than it was for those cohabiting. And we were interested in whether people were able to adhere to these rules and whether the need for sexual intimacy might play a role in transmission of SARS-CoV-2. At 4 months, we found that 1 in 10 participants reported physical intimate contact with a romantic and sexual partner from a different household, and this was more common in younger people and those in steady and non-cohabiting relationships. We actually discussed this finding with some modelling colleagues, and they felt this was unlikely to play a major role in the course of the pandemic, since most transmission occurs within households or where large groups are gathered, such as at school. However, it seems likely that intimacy needs played an indirect role via widely publicised stories of high-profile leaders flouting the very rules that they set for the rest of the population. Most recently, our health secretary was caught on camera being sexually intimate with his senior aide, at the same time as ordering everyone else to keep 2 meters apart from each other. Although he did eventually resign, there is a likely detrimental effect on people's willingness to adhere to restrictions at a population level. You can learn more about this on Sonnenberg's presentation 5.1 and Maxwell's presentation 5.6. Maxwell presents qualitative findings that suggest that individuals who did have sex across households actually thought about this very carefully, weighing up the risk of COVID and rule breaking against their need for intimacy and their need to continue their relationship. So now let's look at how often people had sex during the pandemic. This slide shows the median number of occasions of sex in the past 4 weeks among people aged 16 to 44. If we look first at the green bars, which show 4 months into the pandemic, survey 1, and 1 year into the pandemic, survey 2, both show a median number of occasions of two occasions of sex in the past 4 weeks, with an interquartile range of between 1 and 6. So that's 75% of people had sex between 1 and 6 times in the past 4 weeks. To put that in historical context, we can see the medians for past Natsal surveys. Moving up the figure, we see that in Natsal 3, the median was 3. In Natsal 2, which took place in 2000, the median was 4. And in Natsal 1, which took place in 1990, the median was 5. So it's possible then that the median of 2 in Natsal-COVID is in keeping with a downward trend in the frequency of sex over many decades. Or it could be that the median would have plateaued at 3 had it not been for the pandemic. And we will probably need to wait for the Natsal-4 survey findings to find that out for sure. In the meantime, though, to help us understand this trend, 4 months into the pandemic, we asked participants whether they'd perceived a change in the frequency of sex. Half of participants did, and the other half did not. Furthermore, a third perceived a change in their level of sexual satisfaction, while 2/3 did not. When we looked into this further, we found that among those reporting change, declines were more common than increases, particularly among people who were not in a cohabiting relationship. And if you'd like to hear more about this, you can look up Mercer's oral presentation 5.5 in the conference. Continuing on the theme of sex life quality, we also asked participants 4 months into the pandemic whether they'd experienced sexual difficulties that started or worsened during lockdown. Among those in steady relationships, around 1 in 10 reported this. And again, that you can find out more about this in the Mitchell presentation 5.3. We also asked participants about their level of sexual satisfaction, distress about sex life, and avoidance of sex in the past year. With caution, we compare these findings to similar questions asked in Natsal 3 10 years ago. This slide shows the data from Natsal-COVID in full colour, the data from Natsal 3 in hatching. Women in orange, men in green. We've also split the data into those who were active, so who had at least one occasion of sex in the past year, and inactive, so those who did not. So, for instance, in the first chart, the comparisons are between the sexually active groups, the first and third pair of bars, with the inactive second and fourth pair of bars. So these data suggest that dissatisfaction was slightly higher during COVID, particularly for those who were sexually active. Distress was also slightly more common during the pandemic than 10 years ago in Natsal 3. In contrast, it looks like fewer people reported avoiding sex, perhaps reflecting the reduced opportunity to have it. It's also worth noting that we see very similar gender patterns in Natsal 3 and Natsal-COVID, which does give us some confidence in the Natsal-COVID findings. Moving on to steady relationships, 4 months into the pandemic, we asked participants in steady relationships whether they perceived changes in 5 aspects of sex life quality, things like pleasure, frequency, satisfaction, and 6 aspects of relationship quality, things like connection and partner support. Perceiving a change in sex life quality was almost twice as common as perceiving a change in relationship quality. And where change was perceived, sex life quality was more commonly reported to get worse, whereas relationship quality was more commonly reported to improve. And there's more on this in the presentation by Mitchell 5.3. After 4 months, we also found that 7% of those in steady relationships had reported a deterioration to a lower quality relationship compared with the months before lockdown. And reporting this was associated with worsening sex life, poor mental health, and for women only, not living with a partner. Again, you can find more on this in Mitchell presentation 5.3. With respect to relationship dissolution and formation, we found that after 1 year of the pandemic, 9% of men and women reported a relationship breakup. Among these participants, 60% said that the pandemic played a role in their relationship breakup, and 34% said it played no role, with 6% unsure. On a happier note, 11% of women and 16% of men formed a new relationship in the past year. In the first Natsal-COVID study, we were hesitant to ask about intimate partner violence, given the risk of distress and possible harm to participants if their responses were seen by a perpetrator. By the second survey, the balance had shifted in favour of asking this. The need for information had intensified, and other national surveys didn't seem to be collecting it. In consultation with Ipsos Mori, we sought to minimise risk. We sought to minimise risk by keeping the module brief and by avoiding questions on the most severe forms of physical violence. We emphasised the voluntary nature of the question, and we signposted to sources of help. This slide shows the introduction to the module and the key question, which was, has a partner or ex-partner ever made you feel afraid of them based on their words or actions? So specifically, the question is about fear of violence rather than violence itself. So this slide shows the proportion reported fearing a partner ever and in the past year, with women in orange and men in green. Just over 30% of women reported ever having felt afraid of their partner. About half that many, 15% of men reported this. However, in the last year, the proportions of men and women fearing their partner were both around 8%. And of this group, 3 out of 4 said this had happened more than once in the past year. This slide shows the prevalence of fearing a partner by gender and age group. We can see that this was most commonly reported by those in the 18 to 24 age group, around 15% among both men and women, with the proportions declining steadily by age. This slide shows how people were affected by these experiences in the last year. The top line shows the response options offered to participants, and they were instructed to tick as many as applied. Women's responses are depicted in orange, men in green. The size of the circle represents how commonly each was endorsed. So women were more likely than men to say the experience made them feel anxious or depressed and affected their day-to-day life. Men were more likely than women to say that it made them drink or use drugs more and affected their relationships with family and friends, work or studies. Few people said they experienced no effects, suggesting that the item on fear of partner had measured something meaningful. In terms of whether people perceived that the pandemic had played a role in their experiences of violence, we found that 45% of women and 37% of men reporting that the pandemic had made things worse. 36% of women and 30% of men said it had made no difference. 8% of women and 24% of men said it actually made things better, and 12% and 9% saying that they didn't know. So just to summarize this section, we found that just under 20% of the population reported a new sexual partner in the past year, with highest proportions among young people and declining with age. There appears to be a significant drop in the proportion of people reporting a new partner compared with 2010, but condomless sex at first occasion with a partner remains high. About half of people perceived a decline in the frequency of sex, and the median number of occasions of sex in the past 4 weeks is lower than previous Natsals, with cohabitation status a key factor. Dissatisfaction and distress in the past year were highest among those sexually active and appear elevated compared with those compared with Natsal 3. Sex life quality was more changeable than relationship quality, and people were more likely to perceive deterioration in sex life quality than improvement. 9% of men and women reported a relationship breakup, with the pandemic playing a role in the majority of cases. And finally, just under 10% of men and women reported fearing their partner based on their partner's words or actions in the past year, with the pandemic making this worse for a significant minority. I'm now going to hand over to Nigel.
Thanks, Kirsty. Is that showing okay?
Yes. Yeah, perfect.
Great, thank you. So I'm going to conclude this part of the presentation by presenting data from Natsal-COVID on sexual and reproductive health services, where Natsal-COVID provides a population level view on what has happened across England, Wales and Scotland over a year of the pandemic from March last year. So although most people in the Natsal-COVID sample had not needed or reported not needing services during the past year to March 2021, and that corresponded to just over 80% of men and just under 70% of women aged 18 to 44, this did mean that nearly 1 in 5 men and 1 in 3 women had needed sexual or reproductive health services during that time. And overall, 11% of the sample said that they had been able to access the services that they'd needed, which is shown here in the darker shading, while 10% in both genders reported being unable to access services at least once, which is the top hashed bar. And a further 3% in both genders said that they had needed services but hadn't tried to access them, shown here in the dots. Among those who reported at least one failed attempt to access a service, 82%, so the vast majority, told us that they had also been able to access at least one service. This was often, but not always, the same service, suggesting that many of those initially failing did get there in the end, and I'll come back to that in a little bit, in a few slides' time. We found a similar proportion of the sample, so 1 in 10, reported unmet need for services in the first 4 months of lockdown in wave 1 of Natsal-COVID. And you can see more detail on this in Emily Diemer's presentation 4.4. I'm going to focus on STI-related services for most of the remainder of the presentation. And I'm going to give you a whistle-stop tour of the headline data that are emerging from Natsal-COVID Wave 2, covering the year since the first UK lockdown started. I'm going to show you some data on service use, on chlamydia testing, HIV testing, and also on pregnancy and cervical cancer screening. Part of the context for the Natsal-COVID data is, of course, the most up-to-date surveillance data from Public Health England, and these are shown on the slide here. And these show sexual health consultations for 2019 in the beige lighter bars, and you can see that that was fairly constant across the whole of that year. While in the first half of 2020, which is in the darker green bars, there was an initial very sharp fall in the number of consultations between January and April, before there was a quite striking recovery during May and June to levels that were almost the same as pre-pandemic levels. And at the same time, as many of you will know and have experienced in your own countries, there was a rapid pivot to internet consultations, shown here in the yellow-orange line. I'm also going to show you a comparison, as Kirsty did in several of her slides, between Natsal-COVID and Natsal-3, with the same caveats, remembering that Natsal-3 was undertaken in 2010 to 2012. And so it's worth keeping in mind that the absolute number of sexual health consultations in the UK has risen year on year, shown here in the line above the bars, which are the number of diagnoses over the past 5 years and more. So in the Natsal-COVID sample, just over 8% of people had used a STI-related service in the past year. And that includes here STI testing, STI follow-up care, and reported HIV testing. And this was similar for women and men overall, but not shown here, much higher for MSM at 36%, so over 1 in 3 MSM in the sample reported this. As one way of understanding changes over time, we also asked participants to recall their STI service use in the year before the pandemic, so in the year before March 2020. And actually, these data look quite similar, albeit potentially suffering from a different form of recall bias. And as I said, we can compare to the Natsal-3 data set from a decade ago, shown here on the far left in each group. And while there are differences, bearing in mind that the y-axis is only up to 20%, these are just a % or 2 overall. And taken together, I think at this sort of headline level, it appears that service use in the past year might not have fallen by as much as we might have feared, and that the rebound in service use shown in the PHE data may have continued over the year. And I'm looking forward to the PHE data being released, I hope in an understanding in a few months' time, and we'll be able to compare those to the Natsal-COVID data. Among those reporting usage of STI services in the past year, around half reported using a specialist sexual health clinic or GUM clinic, with a family doctor or a GP making up a further third, and private and other services making up 10% or less. And you can see there are some differences between men and women, but these trends were broadly similar. We know that STI services had to transition very rapidly away from face-to-face consultations due to the lockdowns and need to prevent transmission of COVID. And amongst the participants reporting service access, a half or less had done so face-to-face, while telephone and other online services were reported nearly as often. We found consistently in wave 1 and wave 2 that video consultations were reported far less frequently by both men and women. And we were able to ask the nearly 3% of people who reported failing to access STI services what happened next. And it was somewhat reassuring that only 15% reported that they were still trying to access the service, and just under 30% reported that they had stopped trying to access the service. So the worst outcomes, if you like. Most, as I said before, seem to have got there in the end, albeit not always exactly the service that they intended, or that they needed to use it in a different way. I think one of the really striking findings from Natsal-COVID wave 1 was that we found that 1 in 5 men, so 20%, reported needing condoms during the first 4 months of the pandemic or the lockdowns in the UK, but being unable to access them in this period. While we don't actually know what this would look like in normal times, because this is not a question that we've asked before in Natsal, and I think we should do in the next survey, we saw a similar proportion reporting this difficulty in accessing condoms across the whole of the past year. And here you can see that this was actually much higher in MSM, particularly for younger MSM, where around half of young MSM reported this, while it was still present, but much lower in women. And some of the qualitative interviews that Kirsty mentioned at the top of her presentation that were undertaken in October to November 2020 were enlightening about people's service access experiences. So we followed a group who reported difficulty in accessing services, and some of the quotes are shown here on the slide. I think illustrating on the left the difficulty experienced in trying to get hold of contraception and condoms during lockdown. On the top right, concerns expressed by a young man about whether it'd even be appropriate to access condoms and HIV testing during the pandemic. And then in the bottom right, the frustrations experienced by a young woman who wanted to access STI testing while apparently being symptomless, and her difficulties in doing so. And you can see more of these data in the talk show number 7 and the oral presentation by 5.2 by David Reed. And the talk show presentation, or the talk show I should say, is this afternoon. So what about chlamydia testing? Well, the context for chlamydia testing in this country over the past decade is a significant annual reduction in the absolute number of tests in young people, which is linked to our national chlamydia screening program targeting people aged 15 to 24. Although you'll see that this did stabilize in 2017, 18 and 19. In Natsal-COVID, we found that just over 5% of all people aged 18 to 44 who were sexually experienced reported a chlamydia test in the past year. And this was higher in young people, particularly in young women. Aggregating now by age, you can see that it was even higher in men who have sex with men, at around 1 in 6 of this group. However, now in crosshatch compared to Natsal-3, undertaken 10 years ago, chlamydia testing was very much lower in Natsal-COVID. In fact, around a quarter or a half in all groups of the figure in Natsal-3. And this probably reflects both a fall in testing over time, which I showed you, as well as a potential COVID and pandemic effect. Interestingly, though, this does not seem to have been purely a reduction in need, since we saw that only 19% of those with at least one new partner in the past year also reported a chlamydia test in Natsal-COVID. And that's compared to 39%, so more than double that figure in Natsal-3. For HIV testing, this has actually been going in the opposite direction to chlamydia testing over the past decade, with increases in each year, largely due in the last 5 or 6 years to internet testing. And there's also anecdotal evidence that the It's a Sin drama about a group of gay men and their friends living through the HIV/AIDS crisis in the 1980s coincided with a spike in HIV testing uptake when it was shown in the UK in the first few months of 2021. So overall, just under 8% of the Natsal-COVID sample said that they had tested for HIV in the past year. And this was again higher in young people. Compared to Natsal-3 10 years ago, the figures here actually looked similar. But I think it seems likely that the past year might still represent a drop on what would have been seen had the pandemic not happened. And it's noticeable that less than 30% of men who have sex with men reported an HIV test in the past year. And this is a group that many of you will know has been very successfully targeted for HIV testing in recent years. Moving to pregnancy, we asked participants about their experience of pregnancy in the past year, and I'm just going to show you one slide on this. 12% of women aged 18 to 44 reported being pregnant in the previous year, which was not very different to the proportion in Natsal-3 10 years ago, which was 14%. There were, however, much greater differences evident in pregnancy planning. So in Natsal-3, just 4% of these pregnancies were measured as unplanned using the London measure of unplanned pregnancy, and that's compared to 16% unplanned in Natsal-3. And looking at the stacked bar charts on the left and the right, we observed a general shift towards ambivalence in Natsal-COVID, away from both planned as well as unplanned pregnancies in Natsal-3. We saw similar proportions of terminations, 12% in Natsal-3 versus 9% in Natsal-COVID. But I should note that there has been a really remarkable drop in teenage pregnancies in the past decade in the UK. And so the underlying trends here are a really important part of a very complex picture that we're still reviewing and debating on interpretation. Finally, I'd like to show you some data on cervical cancer screening in the past year. So in these slides that follow, the peach-coloured boxes represent 100 women and trans people who represent the Natsal-COVID sample aged 25 to 59, who would have been eligible for cervical cancer screening based on the UK guidelines, which you can see in the bottom left. And we can estimate, based on the guidelines, that 26 out of every 100 women should have been invited for screening in the past year. And using our understanding of coverage data from before the pandemic, which is about 70% in a normal year, we'd expect 18 out of 100 to have attended cervical cancer screening. In fact, in the Natsal-COVID sample, we found that only 10 out of every 100 reported attending screening in this past year. And this is consistent with a large fraction, perhaps up to 8% of all women, or 1 in 3 of those eligible, who might have missed their screening appointment. Okay, so putting all this together in summary, we found that less than one in 5 people, as Kirsty has said, reported a new partner in the first year of the pandemic to March 2021. And that compared to more than 1 in 4 in Natsal-3, which was undertaken 10 years ago, with the most marked differences in young people and MSM, who we know to be among those at highest risk of STIs. We also found that nearly 1 in 3 people reported using sexual or reproductive health services in the past year. And I think these data really emphasize the importance of these services during a period where other health priorities might be thought to have taken precedence. We know that services switched online and did so very rapidly, and in many cases very successfully. However, we found that 10% of people consistently still reported trying but failing to access at least one sexual or reproductive health service in the past year. And we found really interesting qualitative and quantitative evidence about the difficulties that people experienced, including showing that persistence was often needed in order to access services that people needed. And when they did get there, it was often delayed, sometimes wasn't possible in the way that was intended, and sometimes required workarounds by the participants in Natsal-COVID. We found evidence that chlamydia testing was quite substantially lower compared to Natsal-3, but sexual health clinic usage and HIV testing seemed to be similar to 10 years ago. And as I've said, the picture is complicated, and interpretation needs to consider not only the methodological differences between the surveys, but also the underlying changes over the previous decade before we can attribute changes to the impact of the pandemic. For me, I think one of the really important take-homes was the very large fraction of men, particularly young MSM, who reported difficulty accessing condoms. And I think this needs some thought. And importantly, I think up to 8% of women and trans people overall, and 1 in 3 of those eligible who may have missed cervical cancer screening in the past year. So what does this all mean? And can we kind of come up with a so what for patients and the general public, for their communities, for clinicians, commissioners and policymakers? I think one of the $1 million questions is what has happened to STI incidents. And I think it's possible that STI incidents may have reduced, given what we've observed about an apparent reduction in partner change, which we know is a key driver of STI incidents, together with an observed reduction in sexual frequency at a population level. And it's possible that prevalence might also have fallen for some STIs, particularly those with a shorter duration of infection. Although I think we would need to take account of how changes in testing and treatment have influenced the overall picture. Overall, though, I think that the data provides some plausible parameters for the modelers to help us answer these questions in advance of observational data that I hope we'll get through Natsal-4 and other studies. It's even more difficult to guess what happens next. I think there are rightly concerns that the end of the lockdown might lead to a surge in risky sexual behavior and possibly an increase in STI incidents. But it's very difficult to predict what's going to happen next. And I think we're going to have to watch and monitor this carefully. Although the demands for services may have reduced, we nonetheless found a significant fraction of people who reported sexual risk behaviors and unmet needs. And I think together this suggests there may be some backlog of HIV and STI testing that has accumulated over the past year. The groups needing services may have reduced in size, but the main groups we observe at risk remain the same, particularly young people and MSM. And it's worth remembering that many of these have complex and intersecting needs that require holistic services in rebuilding after the pandemic. And online services, which have been deployed incredibly rapidly and bring tremendous opportunities, have been deployed in a way that really wouldn't have been possible had the pandemic not happened. And there's much to be lauded there. But I think there are also risks which have been discussed in many other fora in this conference, including that those who are unable or unwilling to navigate online services may be left behind in the new world, and they need to be considered. I think the cervical cancer screening program needs careful thought and may need some form of catch-up initiative. And finally, I think these findings provide important context for forthcoming surveillance data, and I hope for Natsal-4. So watch this space. Natsal-COVID has some really important strengths, including that it was done extremely quickly and used Natsal questions and expertise, and it was relatively cheap and achieved a quasi-representative sample that we hope has broad generalizability. But there are important limitations, and Kath is going to discuss some of these in the next section. The preprints of Natsal-COVID Wave 1 papers can be found at the following links, and we hope to publish the headline findings, many of which we've shared with you today from Wave 2 as soon as possible. So it just remains for me to say a really enormous thank you to the team, because as Kirsty said at the top, it really has been a huge team effort. And to you for listening. I think we're really interested to hear your thoughts and comments on the data and the implications. As Kirsty said, we only got the clean data back a few weeks ago, and so this is really ongoing work, and interested to hear your thoughts in how we take this forward. So thank you.
Thanks, Nigel. So we've got a few questions in the chat. Kirsty, do you mind if I just direct this first one to you? So an anonymous questionnaire says maybe they didn't hear it. I don't think they did, but how did you decide on which specific topics or questions to put in your questionnaire to make sure that it was comprehensive?
So I guess broadly that was guided by Natsal's holistic framing of sexual and reproductive health, which has been sort of growing over the years, and we kind of see not just about STIs and unplanned pregnancy, but also about sexual well-being and intimate relationships. We were very lucky because we had just done the stakeholder consultation for Natsal-4, so we had a good sense of what professionals and stakeholders out there were telling us were important things to ask. To an extent where we could, we were keen to include the same items from Natsal-3 so that we could give you that sort of context and comparison. And this was easier to do in the second survey because we had that 1 year time frame, and the first survey took place after 4 months, and that's a little bit of a short time period for reporting of a lot of sexual behaviors. And that's why some of the questions on the first survey focus more on people's perceptions of whether things had changed. Then we were also guided about what was going on with the pandemic, how that was changing people's lives, and what we might need to capture in that result. And so compared with, say, Natsal-3, there was more of a focus on service use because we sort of anticipated that was likely to be disrupted by the pandemic, but also on relationships, because one of the key things about the pandemic was that it was forcing people to stay within their households and restrict their interaction with other people. And so we wanted to focus on the implications of that for sexual mixing, but also for people in relationships who were either stuck in the same household for long periods with the same partner, or living apart from a partner, and those challenges, or would be otherwise, out and about and perhaps looking for a partner and were denied those opportunities.
Thank you for that.
So there's a number of questions that have come to me. So a feeling at the outset that perhaps maybe a third of people didn't have sex with anyone, and over 90% of people appeared to comply with staying inside their houses, home relationships in the first wave. Was that surprising, as a perception in the media was at the time that people wouldn't and couldn't do that? And then is there any evidence in Natsal or elsewhere in sexual health research that this high impact would decrease as time goes by?
So just to take that second question first, we should be able to look at whether there was a decrease in that adherence. I mean, as I said at the beginning of my presentation, it was a bit fortuitous that both the first survey and the second survey took place at the end of quite a long period of full lockdown. We haven't yet analysed that data, but we would be able to hopefully comment on that in future. In terms of whether it was surprising, I think that's probably quite an individual thing if you're surprised by that or not. I suppose I was a little bit surprised. I think it's a massive ask, and I think we will be able to see in future the I think when the leaders who are asking us to do these difficult things were then found not to adhere to them themselves. I haven't seen the evidence. You know, I don't know whether we'll be able to pick up on that particular the sort of Hancock effect, as I'm sure it will become called, in our data. But you know, I think there is data from elsewhere that shows when that there is a real dent in people's resolve to adhere when they see. I mean, we definitely saw that effect. We saw a Dominic Cummings effect. So I would think we'd see a similar Hancock effect.
Would it be true to say that the greatest adverse impact of COVID-19 responses in the sexual health context was on the under 25s? And
do you want to take that one, Nigel?
I think that young people have really suffered in the last year and a half for a whole range of reasons. We didn't show the data here, but it was really striking in the wave one, the proportion of people who reported depression or anxiety symptoms, and that was most likely in young people. Young people were more likely to not be cohabiting with their partner, and the restrictions due to lockdown therefore had greatest impact on them meeting with partners and their sexual well-being. And it's, I think, interesting to see the impact at a population level that we're now seeing a year on, and comparing to Natsal-3, in the number of partners that people reported. So I think it is one of the stories that emerges from Natsal-COVID that young people have been hit particularly hard.
Mm-hmm.
So there's also a couple of cluster of questions coming up. See if I can. So perhaps maybe a comment, and it also relates to how you in part ended, Nigel. So a reflection that condomless sex appears to be increasing. Some of that may have been problems accessing care, problems accessing condoms. Is that an immediate recommendation that we perhaps should be promoting condom usage and condom covered sex as the pandemic continues to fluctuate? Is this a call to arms or call to condoms for us?
I mean, I'm never ashamed to say that condoms are important. I think that they have a really important role. They're in all of the new interventions, new technologies, new things that happen. They're easily forgotten, and they do have a really important role. They're not for everyone, and they don't always work, but I think it's too early to say, and we weren't able to measure actually a change in condomless sex between Natsal-3 and Natsal-COVID, but it is striking that a large proportion of people who reported a new partner in the past year didn't use a condom. And as I said in my summary, I think it's striking that that difficulty accessing condoms was something that was reported by young people and men who have sex with men. I saw there was a clarification question on that, which I can also take, which was about whether the question was about accessing free condoms from sexual health services or condoms more broadly, which would include from pharmacies and petrol stations and wherever else they might be sold. And the question was not phrased about free condoms, it was phrased about condoms. It didn't specify where or how. So it was a general condom access question.
Thank you. Kirsten, had you any comments, or shall I go on to?
That's fine. Yep.
Okay. So there were a number of questions within the context of intimate partner violence. So I think one, do you have information about same-sex relationships and or numbers that might give rise to data in that context? A second question following on from that was the impact of activity, the impact of fear of violence or partner violence on activities of daily life. Are there wider sources of data about experience of actual violence in people who have a founded fear? Perhaps this might be getting to the question, is that a safer question to ask than has violence taken place? Is that or is it an entry question when talking about partner violence? And just, there was a third one in the chat that, again, on the same theme, if I can just get it up. Actually, probably the same thing from Jane Merrick about, did you ask about the differentiation between sexual violence and or domestic violence in that context? So
yep.
A little complex bunch.
Okay. So I think the first thing to say is that the questions on intimate partner violence represented, quite a difficult compromise between the need for information and accurate information and the need to ensure participant safety and minimize distress for participants. So it's very difficult, and I think the question that we asked really just skirts the surface at the end of the day. We were trying to encapsulate the trouble is, it's like everything, when you start to get into these, there are so many dimensions to intimate partner violence that to ask it comprehensively, you actually need a full module. And at one point we did have a full module, and then we backtracked and we reduced it to this single item, which was our best attempt to try and capture the main dimensions of violence, which to try and get at the idea that violence is not just physical, it can be verbal, it can actually be economic and all sorts of other things. But those two, when we got into the question, the words and deeds, the words and actions, and then to try and, without being too vague, to really be clear that this was something that caused people to feel fearful. So just to answer one of the questions was that we didn't differentiate between sexual violence as distinct from domestic violence. It was a very broad question. It was just that one question. And yeah, we wanted to be able to, for people to be able to get through the module quickly, because you cannot, it's very different to a face-to-face interview, which is what we do in Natsal-3 and the other Natsal surveys. You can't ensure that the person is safe, and you can't do anything for them if they're distressed. So that's why we've ended up with this kind of sort of fairly broad question. And we signposted to sources of help, and we had a very gentle introduction, and we really emphasized that people could opt out at any point in the module. And then going back to the first question about same-sex behavior, I mean, looking very preliminary, we've started to look at that, but I'm a little bit hesitant to kind of present the results just because they're far too hot off the press, but there do seem to be some differences along those lines.
Thank you very much. Professor Mercer, have we more time, or?
You're chairing, John. We can always revisit some of these questions at the second Q&A if you would like to, and we can also respond through typing. Yeah.
Because I think there are potentially some questions for the second, but I might just end on coming back to Nigel. So there's a question from Ashokar Tete about ambivalence in pregnancy planning and reporting. So what does that mean? And what was our overall interpretation of the greater level of ambivalence in Natsal-COVID? Is that in a time of pandemic, we just say whatever happens, happens?
Well, so the technical question first. The definition is based on the London Measure of Unplanned Pregnancy. And if you put LMUP into Google or your favorite search engine, then you can find that as a great website by the team behind the measure, which includes the different versions, the scoring and so on. But the bottom line is it's a 6-question measure, which has scoring 0, 1 or 2 for each of the measures, and planned, unplanned or ambivalent is based on the scoring of those for people who report a pregnancy or were pregnant in the previous year or 5 years, depending on how you're using it. I think the interpretation question is really interesting, and we could probably spend the rest of this seminar debating it. As I said, there have been massive changes in unplanned, certainly unplanned and teenage pregnancy in the UK. I'd also go back to the mood and depression and anxiety that is being very frequently reported, not just in Natsal-COVID, but across many social surveys that have taken place in the last 12 to 18 months. And people's feelings and moods will influence the way in which they respond to these types of questions, and that may have a role here. I think the final part is that it's actually too early to say, because we were literally looking at these data last night and finalizing them, and I haven't had a chance to do the sort of due diligence of looking through the data in a huge amount of detail to give you that kind of answer, but that will be something that we will be really interested to do and report as soon as possible.
John, before
Yes.
we go on to the next presentation, can I just pick up on the question on gender, because it's an important one, and it's quite quick. So it was just to say that we were inclusive in our approach to gender. We asked 2 questions: how you think of yourself now, and then saying that, you know, and then how your sex assigned at birth. And so we were able to then measure trans histories, and there were 61 trans participants in WAVE in the first survey and 67 in the second survey. And when we talk about men and women, we're including trans men and trans women in those in those groups, because the numbers are too small to present separately.
Fantastic.
And sorry, and when we're presenting all, that is including everyone, including non-binary people.
Thanks.
Thank you so much. So, Professor Mercer, are you ready to come back in?
I can, yep. I'm going to share my screen. Thanks very much, Kirsty, Nigel, John, Claire. See if this is going to work. Okay, can you see that?
Yep.
Yeah, fantastic. Thank you. So in the second half, I'm going to be reflecting on the methodological challenges of researching sex in a pandemic, recognizing how Natsal-COVID needed to balance pragmatism and the need for actionable public health data with quality and scientific rigor. But despite the many successes of Natsal-COVID, also, I'm going to talk about why we still need the decennial Natsal and the somewhat bumpy road we're on in delivering this, with COVID requiring us to rethink data collection, amongst other things. I'm going to talk about where we are now and also why we still need you. So Natsal-COVID has already informed policy and practice, with the Wave 1 data presented to, amongst others, the Scottish Government, Public Health England, Terence Higgins Trust. So impacts that reflect how Natsal-COVID is recognised as having used the best possible study design given the circumstances, reflecting how Natsal's traditional approach, so a probability sample with in-person interviewing, were not possible due to physical distancing rules and the need for rapid data collection. However, at the same time, the Natsal-COVID methodology does have its limitations. Although we use quota sampling and weighted the sample on key characteristics, as we didn't use probability sampling, then the data can't be considered as truly generalizable to the general population. It's also well established that estimates from online panel surveys need to be treated with proportion, given likely selection and response biases. Furthermore, as an online survey, Natsal-COVID excluded those without internet access, which in the UK is estimated around 1 in 8 adults, with this proportion higher among those in lower social grades. We also know from previous research, including work that we did as part of Natsal-3, that web panel quota sampling leads to sexual behaviour estimates that can differ to those achieved through probability sampling. In this respect, when we made comparisons with the last survey, albeit over a decade old now, we found that the Natsal-COVID sample was less likely to report partnered sex ever, but amongst those who had had sex, then there were similarities in terms of the reporting of partner numbers and same-sex experience, which provides some reassurance. Finally, as a self-administered online survey, the breadth and depth with which we could investigate sexual behaviour and health was limited, with Natsal-COVID survey taking around 10 minutes on average to complete, in contrast to the decennial Natsal surveys taking around 50 minutes on average. However, in terms of questionnaire content, it's worth noting some silver linings in COVID. Firstly, that we've been able to use new questions that we developed for Natsal-4 in the Natsal-COVID survey, including, for example, asking about sex and gender identity, for which you can find more information from Joe Gibbs' poster, number 365, and also on online partner seeking behaviour, which David Reed's poster presents. So that's poster 257. Such that Natsal-COVID has also served as a pre-pilot survey for Natsal-4 in terms of assessing the acceptability of new questions and how these are understood. And conversely, the questions we needed to develop for Natsal-COVID, specifically relating to COVID's impacts, we've incorporated into Natsal-4 as part of modifying Natsal-4's content to take account of the pandemic in its questions and the response options we offer participants, to ensure that Natsal-4 continues to be fit for purpose and address contemporary issues. Now, the limitations of web surveys have been recognised for some time and was one of our conclusions when we undertook a scoping review back in 2018 to consider the most appropriate methodological approach for Natsal-4. And you can download the scoping review and a summary that was published in STIs from the Natsal website. So we evaluated, in the scoping review, we evaluated 7 alternative study designs in terms of their ability to meet Natsal's data collection requirements, shown here. And we concluded at that time that the optimum approach for Natsal-4 remained a probability sample survey using interviewer-led in-person data collection, and that moving some or all of Natsal-4 online wasn't an option, at least then. However, because since COVID, we've seen shifts in how we communicate, with many people now very comfortable with using video conferencing, even though we don't necessarily like the quantity of Zoom and team calls that many of us now have. So it made us think, might there be opportunities in terms of participants in Natsal-4 being willing, or even more willing, to do a Natsal interview remotely rather than in person? Now, we're putting this hypothesis to the test, although rather it being an interesting parallel study, it's actually a case of needs must, reflecting the ongoing uncertainty as to the feasibility and acceptability of the original Natsal study design, given COVID and the physical restrictions that are still in place. So we've revisited the 8 design features integral to Natsal, so shown on the left of this slide, and considered how we could best achieve these given the additional challenge of needing to collect data during the COVID-19 pandemic. Now, taking account NatSen's social research, so that's Natsal's fieldwork partners, taking account NatSen's experience from having to rethink data collection to complete other population surveys it's responsible for delivering, as well as Natsal's unique challenges as a highly sensitive survey, we've been considering 4 different options. So from left to right, we've got our original design, pre-pandemic design, and then 3 alternatives. So model 1 considered remote self-completion data collection. So specifically writing to selected addresses and inviting participants to complete a web questionnaire, and then sending a paper questionnaire to those who didn't respond. Model 2 considered remote interviewer-led data collection, which would involve writing to selected addresses and inviting participants to take part in a phone or video conference interview. And that would include an online questionnaire for the self-completion interview. And then model 3 considered in-person recruitment and data collection, but with remote data collection options available. Now, this model is most similar to Natsal's original pre-pandemic design, but has the flexibility for scenarios where in-home data collection is either restricted or unwanted. So we assessed each model against the Natsal design features and gave them a star rating, as you can see. Now, while the remote options, models 1 and 2, would enable the collection of some data, we anticipated significant drawbacks in terms of, firstly, the response rate and subsequent sample bias, as both rely on participants opting in to the study, an inability to include boost samples, so to oversample young people and ethnic minority groups, the need to dramatically reduce the questionnaire length, as we've had to with Natsal-COVID, lower levels of biological sample collection, lower levels of consent to data linkage and further research, and the risk of measurement differences through mode changes leading to time series discrepancies. So based on this review, we opted for the 3rd model, the interviewer-administered survey with the option of remote data collection. Now, before I move on, I would like to say a massive thank you to Anne Connolly at Natsal, who undertook this comprehensive review and has really given a lot of thought to the practical implications of this shift in data collection models, and which Anne has summarised for us in this diagram. So the white boxes at the top describe how initial contact is made with a potential participant and how they're recruited, which is the same for all 3 data collection modes. Now, we had to decide whether to randomly allocate participants to one of the 3 modes, so in person, video call, or over the phone. But we decided that it's more important to assess the likely uptake of each mode. So in the pilot, at least, we're allowing participants to choose a mode, choose one of the 3 modes. Now, the in-person mode is set out on the left of the screen in orange, and the remote modes are on the right, mainly in pink. And you can see that the remote modes replicate each aspect and in the same order as the face-to-face mode. So we haven't removed any elements of the Natsal study. So the self-completion, biological sample and data linkage requests are all still included. The main differences for the remote modes are that the self-completion questionnaire is completed online rather than on the interviewer's laptop, and the biological sample kits are sent after the interview and returned to the lab directly by participants. Now, offering remote modes presents a number of challenges which we've proposed solutions to address and that we're now testing in the pilot study. Firstly, we had to decide how to implement the self-completion elements in the remote modes. So with the in-person mode, the self-completion module is sandwiched between the interview-administered elements. But for the remote modes, it might make more sense to move the self-completion module to the end to avoid order effects and the risk of non-completion. But we've actually retained the original placements, so sandwiched between the two interview-administered parts of the survey, and we're simply asking interviewers to stay on the call while participants complete their self-completion modules. Next, the seemingly simple issue of physical fieldwork documentation, such as the leaflets, show cards, and consent forms. Now, this doesn't have a simple solution for the remote modes. Now, we considered using online versions of these documents or asking interviewers to share their screens on video calls. But for the pilot, we're providing hard copies of the documents to participants on the doorstep when they agree to participate. Although we're concerned that by doing so, by seeing the document pack, might actually lead to some participants cancelling their interview appointments, so changing their mind about taking part. Another challenge we've had to tackle was how to record consent, particularly for the biological samples where historically a wet signature would have been obtained. For the pilot, we've moved to an e-consent process, which also eliminates the need to reconcile paper consent forms and the risk of missing forms, particularly for remote modes. One of the biggest adaptations has been the changes to our biological sampling protocol, and for remote interviews, we've considered two possible options. Firstly, interviewers returning to the home of remote participants to administer a socially distanced collection from the doorstep, or sending self-collection kits in the post and asking participants to return the samples themselves, which is actually what we're now piloting, even though this means that the protocol differs for in-person and remote interviews. Finally, a major consideration has been around the potential risk of harm to remote participants. As you know, the Natsal interview contains some extremely sensitive topics, and so interviewers play an important role in assessing privacy, which is obviously harder to do remotely. But also because the interview can be distressing, so another important role for the interviewers is to ensure that the correct signposting and safeguarding procedures are followed, which again may be more challenging to do remotely. To address these challenges, we've implemented additional safeguarding measures for remote interviews, including an exit button in the online self-completion module, which navigates to the BBC News webpage. However, we're concerned that this could actually lead to an additional risk of harm to participants. And so we're going to be seeking feedback from pilot interviewers and participants on this to inform our approach for the main survey. So where are we now? Well, after a year's delay because of COVID and having to rethink data collection for Natsal-4, I'm pleased to report that the Natsal-4 pilot is finally underway. We're paying strict adherence to NatSend's COVID-19 health and safety protocols, which are enabling us to offer pilot participants all through 3 modes. And although we still have a couple more weeks to go, so far it looks like in-person data collection is the most popular mode, although this may change as COVID cases are rising in the UK. A second triumph is that this week we started our qualitative follow-up interviews with those survey participants who agree to this, so currently around 3/4, taking part in an interview to understand how they found the experience of taking part in Natsal, as well as the actual content and length of the survey. Now, these quantitative and qualitative pilot data from participants, along with feedback from interviewers, will all feed into a report that we'll review as a team in September, which will inform modifications that need to be made ahead of our dress rehearsal, so a second pilot, which will take place early next year to test out the pretty much finalised, or we hope by then, the finalised processes, procedures and content of the survey before the main stage, so the field work for real, starts early summer next year. I should add that in parallel, we're exploring the feasibility of using an alternative sampling frame. So rather than sampling randomly selected addresses, which is what Natsal's done to date, we're exploring whether we can use GP, so primary care records, to enable us to randomly sample only those people in our target population, so specifically those aged 16 to 59 for Natsal-4, which is considerably more efficient. Now, this approach has been used by COVID-focused research studies, and so we're hoping that Natsal can capitalise on this experience, although I should add that there are lots of hurdles to jump, and so it's far from a done deal at present. So as I wrap up, a reminder that we still need you. Natsal's mission is to create the most beneficial resource for the most beneficiaries, shown here on the right, to exploit and to help us grow. Therefore, we're really keen to collaborate with you to make sure that the Natsal resource meets your practice, policy and research needs. In this respect, you may remember at the BASHH conference in June 2019 and at the last ISSTDR conference in Vancouver that we were asking you to participate in our stakeholder consultation to add your voice as to what you felt were the most important topics for Natsal-4 to address, and also the topics that you felt were less important. We're really grateful for receiving over 300 responses, mainly with suggestions for topics and questions that we should add, which gave us a real challenge as the Natsal survey really needs to take less than, on average, an hour to complete. Now, if you'd like to find out more about the cuts, so what made it and what didn't and why, then you can download our stakeholder consultation report from the Natsal website. Of course, Natsal's outputs aren't just about the survey data. There's the biobank, questionnaires, validated measures, including the Natsal sexual wellbeing measure that Kirsty's developed for Natsal-4, reference tables, infographics, and what's more, many of these resources are freely available from the Natsal website, including a link, we hope, to this recording, should you feel that you didn't catch everything the first time round. So aside from keeping up to date with Natsal via the website, you can also stay in touch by following us on Twitter, and there's also good old-fashioned email. So finally, thank you. Thank you for watching. Thank you to BASHH for this opportunity and their ongoing support of Natsal, and a special thank you to Claire and John in this respect. A thank you to our funders, of course, and once again, everyone in the Natsal team, our collaborators and expert advisory group. Thank you very much. Let me just stop sharing.
Splendid. So thank you so much, Kath. That was another really fascinating presentation. Let me just give you a moment to catch your breath. But I'll just take this opportunity while we're talking for all of the professors, Professor Mitchell, our newly promoted Professor Field, Professor Mercer and Professor Sonnenberg, who's recovering from COVID today, just to thank you for all of the work that you've put into these presentations. I really feel, just listening to them, sort of a lot of the uncertainties that we've been trying to negotiate with the fog of COVID are beginning to crystallize into actionable, factual knowledge that we can very strongly work with. But I wanted to come to some questions about your presentation, Kath. So just reflecting back, if the limitations of the Natsal-COVID was, in part, it was done online, why are we introducing that in Natsal-4?
That's a very good. Thanks, John. That's a very good question. But I think it reflects the need for pragmatism, as with Natsal-COVID going online and using the web panel approach. For Natsal-4, we're having to be pragmatic. We're needing to make sure that Natsal happens, but we are conscious of the need to make sure that the data we collect are comparable, so that we can look at change over time. And so we're encouraged by the finding, not just from the pilot so far, but also from other studies that have had to shift to offering remote ways of collecting the data, that actually most participants in these surveys are still choosing to do interviews face to face. So yes, it's a necessity to offer online, but we're hoping that yeah, that won't limit people's participation.
So I was interested to hear your comment about introducing the use of the rapid escape home button, taking some news. I'm just thinking as well about sort of learnings from COVID, where particularly we know that populations that have been adversely affected by COVID, particularly those from Black and minority ethnic Black populations in the UK, many of whom where English may not necessarily be their first language. Is there exploration of the translate button, or are we, just because of methodological realities, we operate in English? Is that an area for consideration of future online surveys?
That's a good question, John, and it's something that we have thought long and hard about. When in Natsal-2, when we included an ethnic minority boost sample, we did translate the questionnaire into 2 languages other than English, but it wasn't felt that this was necessary for the Black ethnic minority groups. And so, given that they're really our priority when we think about the epidemiological data, we don't feel that that's essential for Natsal-4. And obviously there are cost implications of making the questionnaire available in different languages. So it's something that we are conscious of, but it's something that we're not doing for Natsal-4.
And is there an argument just about waiting for longer till the pandemic is over, in inverted commas, in order to allow things to settle back to normal and then reassess then? Or what's the rationale?
I mean, there were times over the past year when we did actually just want to go away, hide and come back and do Natsal when the dust had settled, shall we say. But I think the important thing to remember with Natsal is that there's never a right time. There's never a normal time. When we think back to the very first Natsal, at the time when there was a huge concern about HIV, risk behaviour was actually very, very low, relative to when we did Natsal-2, where we saw significant increases in risk behaviour relative to Natsal-1. So, you know, when is normal? When is the right time? And I think something that's really spoken to us as a team, given Natsal-COVID and just how people have really appreciated the data that study has been able to generate against the odds, has been the need to get that population perspective, to understand what's going on in terms of sexual behaviour, service need and access at this point in time.
So I suppose, given the sort of the rapid change, the shift to digital, the forced familiarity, web-based engagement, and I suppose climate change and a whole host of things that will come at us more rapidly, is there a need for frequent, perhaps web-based survey versions of Natsal? Is a decade frequent enough given the rate of change?
Well, we would love to do Natsal more frequently, but I think it would kill us all. No, it's Natsal, the decennial Natsal is a huge effort. You know, we've had 2 years of development work feeding in to create Natsal-4 to make sure it's fit for purpose when we field it next year. But I think what we've learned from Natsal-COVID is that there are advantages to doing something that's short, quick, still large, that can bridge that gap between the decennial surveys. And so I would love to think that there's the opportunity to have that stepping stone between decennial Natsals to give a more up-to-date picture along the way. Watch this space.
Thank you, Kath. And just perhaps in our last minute, Nigel or Kirsten, were there any key messages you wanted to, one or two messages that you wanted to impart before we leave?
I suppose for me, I'd say, you know, we've got now a picture of what's happened in the last year, and in some ways, you know, one of the two things that really come out are how well services have adapted, and how much they've been able to do in the midst of a pandemic, when so many, you know, the broad picture of other health issues really taking a back seat. The other one is the risk and reduction, but I suppose the sort of take-home messages, please keep watching this space, because we don't know yet now how people will compensate, if they'll compensate, you know, how people's attitudes to what and particularly for young people, we've had a whole generation of young people who should have been having their first years of sexual experiences and haven't, and who've missed out on education, and we've had to compromise some of our messages around prevention because we've been rationalizing services. And so I think, yeah, we probably need to steel ourselves for the next few years.
I think we need to pay tribute to the young for what they've put up with for the benefit of those of us around.
Yeah.
Nigel, parting words?
Well, thanks very much for everyone for joining and for great questions, and for the attention that's been enabled to Natsal and Natsal-COVID by BASHH, so thank you. Well, apart from about 50 grand in anyone's pocket that they want to give us to do another few Natsal-COVIDs, I think I'm struck by how much has changed, but also by how much has stayed the same, and I think that's been one of the challenges of interpretation. What I would love to do is be able to do something similar to Natsal-COVID alongside the decennial survey, and then we would really have a good measure of what these two waves have shown us in relation to the probability sample.
So we'll see what we can do. So, thank you all for your time this afternoon. Thank you to all the audience and everybody who joined us in the chat and on the webinar, and who'll be watching later. For those of you who are interested in clinics and various things across the country and across Europe. So congratulations to you all for an amazing job. Well done. And goodbye.
Thanks,
Thank
John.
you.
Thanks, Claire.